and she asked me, since she's supposed to be introducing our group session, and she's not here, I just figured I would just go ahead and talk and start talking. And it seems like it's kind of an informal group, so I don't even know if I need to stand up or even, or if I need to stand behind the microphone. It's totally up to you guys. If you can hear my voice like this, I'm happy to just talk, not behind the mic. I'm not sure how many people there's there, whether we expect a bigger group or whether I should just go ahead and get started. So typically, I would think when I was invited to give this talk that the obvious order of events would be that we would have the surgeon speak first, and then either the medical oncologist or the radiation oncologist. Because in the adjuvant setting, people generally have surgery first, although sometimes, or they at least meet with a surgeon first, and then they go on to chemotherapy and or hormonal therapy discussion, and then go on to radiation. Or alternatively, they meet with a surgeon, they're told that their tumor is too large to have surgery, or that there would be advantages to doing chemotherapy or hormonal therapy first. So then they come to meet with a medical oncologist, and they go to the radiation oncologist. So we're going to pretend that we're working in the neoadjuvant setting today, since we don't have a surgeon here quite yet. And I'm hoping, actually, Dr. Fong mentioned she's actually in the operating room and actually had to end up doing a completion node dissection, so she's going to be in the OR longer than expected. So I'm going to go through my, my 30 minutes or so that I'm going to try to cram in all of the systemic treatment of breast cancer, which I think is absolutely impossible. So there's going to be huge gaps in what I'm telling you about. But I thought the easiest thing to do would be to give you kind of a case-based discussion, to give you a kind of a flavor of some of the decisions we have to make, and give you an idea of some of the data that we base these on. And for those of you who sit in, come to the BOP meeting, some of the data you may have seen before, but there's going to be a lot of slides that just have text points that I'm just going to kind of talk through. And because I am primarily a clinician, and for those of you who sit in the BOP, you see that I leave the room more than anyone else. And it's not because I do have to go to the bathroom a lot, but it's because I have to answer pages a lot. I just need to make sure that there's no urgent patient issues, so I'm okay for the next 15 minutes. No, it's fine. I'm used to it. So anyway, basically, and then as I was talking through this with some of my colleagues who I said, how can I possibly present everything you need to know about systemic treatment in 30 minutes? They said, really we just have to provide broad strokes. And so I really upfront want to give a sort of a differentiation between our goals of treatment when you're dealing with a patient who has early stage disease, where we're recommending adjuvant therapy, versus a patient who has metastatic disease. And our goals are very different. So in the adjuvant setting, our goal is to cure the patient. We want to offer the most, regimens that have the most compelling clinical trial data, where there's a strong demonstrated benefit in randomized phase 3 trials. In the case of the adjuvant therapy, most of the chemotherapy regimens are multi-agent regimens, whereas in the metastatic setting, there's a lot of data on single agents. And then in the adjuvant therapy setting, because these trials take thousands and thousands of women to actually prove a point, there aren't as many regimens that have been tested. So I often have patients who come in to see me who say, well, don't you have to offer something different? And you realize that really everything is kind of a variation on a theme. Patients get an anthracycline and a taxane, and in Europe the anthracycline is epirubicin, in the United States is adriamycin, and some centers use Taxol, and some centers use Taxotere, and some places will throw in a little bit of 5-FU, but for the most part, the chemotherapies offered in the adjuvant setting are very, very similar to each other. And the hormonal therapies also basically are limited to tamoxifen and the aromatase inhibitors. Some of the other hormonal therapies, such as fulvestrant, which is a newer agent, are not even yet being studied in the adjuvant setting because it would take so much time and so much money to do such a trial. In the metastatic setting, our goals are very different. Our goals are hopefully to extend life. And we do have a limited number of trials that show that we can do that, although I'm quite convinced that we are extending life bit by bit, even if the trials are unable to show a survival benefit. Adding all of the 2 to 3 month improvements that we're seeing with each of these studies in terms of progression-free survival. We have patients in our clinic with metastatic disease that have lived upwards of 10 years or greater with ER-positive disease. The longest lived patient I have with metastatic disease has been out 15 years with metastatic disease. Of course, that's not across the board the same for everybody. And then in the metastatic setting, we do have some randomized trial data, but a lot of it is randomized phase 2. There's not as much randomized phase 3 trial, and a lot of times we just are basing our use of certain drugs on non-randomized phase 2 data only. And then finally, our treatment choices are driven not only by the demonstrated benefits in a clinical trial, but they're driven by where the patient has disease, how symptomatic they are, what their patient preferences are in terms of quality of life, whether they're willing to lose their hair, whether they're willing to come into the infusion center and how often, and what side effects they deem to be the most horrible. So there is definitely a lot of art of medicine in the treatment of patients in the metastatic setting.
You gave the sort of the longest survivors. What's the median survival?
So that's changing, I think.
Sort of
yeah.
Best case.
I mean, I'd say the median survival for an ER-positive, HER2-negative patient is at least 5 years now. Although if you go to the internet, it'll, when you look, I mean, they would say something like median is 3 years, but I would say in our practice, median survival is close to 5 years.
Metastatic disease.
For metastatic disease, and triple-negative, 2 years. It's much shorter, and 2 years, it's much shorter. And then, someone who has HER2-positive disease, it can be highly variable because they can have very chemosensitive, very chemosensitive HER2-positive disease. But then if they end up with brain metastases that are very resistant to radiotherapy or not responsive, then they die of their CNS disease, even though their systemic disease is well controlled. I'm right now taking care of a patient who's going to die of her CNS disease, and she has no other sites of distant metastasis. Her systemic disease is very easy to control. So I just thought that I'd start out by giving this case presentation. And so we're here talking about a 49-year-old perimenopausal woman. So by perimenopausal, this is a patient who's still having periods, but she's having some symptoms of menopause. Maybe her periods don't come every month, but we still, for the purposes of treatment, have to consider her to be premenopausal, although she may move into menopause over the course of the treatment. She feels a mass in her breast. She has a mammogram that reveals a density in the upper outer quadrant, and she has an ultrasound that confirms this mass to be measuring about 1.6 centimeters. She goes on to have a core biopsy, which reveals a grade 3 invasive ductal cancer that's estrogen and progesterone receptor positive, as well as HER2 positive. So this patient will give us an opportunity to talk about all the different parameters of adjuvant treatment options that she may need. She opts to go ahead with a lumpectomy and sentinel lymph node dissection, and Dr. Schechter and Dr. Wang will discuss the issues around those choices. And eventually, the pathology report comes back revealing a 1.8 centimeter grade 3 invasive ductal cancer. There's no lymphovascular invasion. The specimen also contains some non-invasive cancer, which from my perspective doesn't matter in terms of my treatment recommendations. So patients will often say, well, but I had 2 kinds of cancer in my breast. I had an invasive ductal cancer and I had a ductal carcinoma in situ. All I care about is the invasive cancer from the standpoint of a medical oncologist. She had a sentinel node biopsy done, and again, Dr. Wang will discuss what that means. But oftentimes when the sentinel node is done, there can either be 2 sentinel nodes that light up, or a second one kind of comes along for a ride. Sometimes 3 or 4 come along for a ride. And we have the good fortune here at UCSF where patient sentinel nodes can be tested in the operating room. And under frozen section, her sentinel node was positive, so she went on to have a full completion node dissection. At the time of her primary surgery, 15 additional nodes were removed, none contained cancer, and the metastasis within the lymph node measured 6 millimeters. And it had no extracapsular extension. Again, Dr. Schechter will talk about the importance of the lymph node size, whether there's extracapsular extension and the lymphovascular invasion, and how that plays into decision-making for radiation therapy. So from a medical oncologist perspective, the things that I care about in terms of guiding a patient, in terms of the pathologic and biological prognostic factors, there are the standard well-known tumor size, lymph node status, estrogen and progesterone receptor status, HER2 status, and then tumor grade. We typically use something called the Scarp-Bloom-Richardson score, which includes nuclear grade, tubular formation, and mitotic index. From the other, some of the other factors that are considered in terms of giving us an idea of the biological aggressiveness of the cancer are the lymphatic and vascular invasion, the presence or absence of that. So if a patient has a lymph node negative cancer, but they have florid lymphovascular invasion throughout their entire specimen, that certainly makes us more worried about the risk of distant metastasis. And then proliferation markers, which some places use S-phase or Ki67. That again can also be very similar, can provide some of the same information as the mitotic index and the tumor grade. Finally, we have information about the histologic subtypes, and interestingly, the histologic subtype of the cancer has very little impact on my recommendations for treatment as a medical oncologist. We do know that certain cancers, such as invasive lobular, have slightly different characteristics biologically. For example, they tend to be, very frequently tend to be ER positive, and they don't seem to respond as well to neoadjuvant chemo.